The morning sun was a pale, forgiving gold, the kind that promised a gentle day. Alex finished his brisk 3-mile loop around the neighborhood park, his breathing steady, his legs strong. He felt, as he always did after his walk, invigoratedly healthy. Yet, as he turned his key in the front door, a familiar, low-grade urgency pressed upon him, a need to visit the bathroom that felt, somehow, more insistent than it had been just a week prior. He dismissed it with the practiced ease of a man accustomed to a body that had always obeyed. Probably just the extra coffee. This was the quiet, biological shift beginning its work. Deep within Alex's pelvis, a walnut-sized gland called the prostate, having dutifully performed its functions for 6 decades, was entering its next, inevitable phase. After age 60, for most men, prostate cells begin a slow, benign multiplication. There is no illness in this, no fault. It is simply a common landmark of the male journey, as natural as graying hair. Yet this gradual growth occurs in a crucially confined space, encircling the urethra, the tube that carries urine from the bladder. Millimeter by imperceptible millimeter, the lumen of that tube narrows. It is a constriction so incremental it rarely announces itself with fanfare, a secret whispered in the language of cellular biology, one seldom translated for the men it affects. Later that afternoon, on the manicured fairways of the municipal course, the whisper grew slightly louder. On the 4th green, as his partner lined up a putt, Alex felt the signal again. He offered a casual, "Be right back," and ambled toward the clubhouse restroom. On the 7th tee, he excused himself once more, this time with a self-deprecating joke about his hydration habits. His friends chuckled, and the moment passed into the easy camaraderie of retirement. No one commented, no one connected the dots. This mirrored a broader, societal silence. Conversations about knees and backs were commonplace, but the inner workings of male pelvic health remained shrouded in private embarrassment and myth, an unspoken agreement to ignore the mechanics of aging until they screamed for attention. Alex buttoned his sweater against the cooling evening. The round concluded. He felt a faint, unfamiliar fatigue, not in his muscles, but somewhere deeper, a subtle drain he attributed to the fresh air. True source, the body's quiet, persistent effort to navigate a newly narrowed passage, remained unexamined, a silent shift underway beneath the surface of a vibrant life. The whisper became a murmur, then a distinct, troubling signal Alex could no longer entirely rationalize away. The urgency persisted, but now it was joined by a frustrating hesitancy. Standing before the bathroom sink each morning, he would wait, the expected flow slow to begin, as if some internal gatekeeper was deliberating. When it finally came, the stream was weak, lacking its former confident force, often splitting into 2 feeble trickles. He chalked it all up to getting older, a convenient catch-all bin for any bodily grievance, a phrase that allowed him to sidestep the prickling unease. The revelation came not from a medical pamphlet, but over a beer with his old friend Mark. Their usual banter about grandchildren and golf scores faltered. Mark leaned in, his voice dropping. He confessed to a recent diagnosis of benign prostatic hyperplasia, BPH for short. He described the same symptoms, the waiting, the weak stream, the frequent trips. "The doc said it's about as common as wrinkles for guys our age," Mark said, a note of relief in his confession. "Most of us just ignore it out of embarrassment or some macho nonsense about toughing it out." Alex felt a jolt of recognition, followed by a cold wave of denial. If it was so common, why did it feel so isolating? The conversation planted a seed, but Alex's instinct was to bury it. He scheduled a doctor's appointment, a vague checkup, but when the day arrived, he invented a conflict and canceled. The thought of discussing the intimate mechanics of urination filled him with a profound, almost adolescent shame. Instead, that evening, he waited until his wife was engrossed in a television program before retreating to his study. In the blue glow of his computer screen, he became a clandestine researcher. He typed symptoms into search bars with furtive glances at the door, his heart pounding as if he were viewing something illicit. The internet offered a flood of information, both clinical and alarmist. He learned BPH was indeed extraordinarily prevalent, a normal part of aging for millions, yet massively under-discussed. He read myths about it being linked to sexual promiscuity or poor character, understanding now the deep-seated stigma that kept men silent. He saw his own behavior reflected in statistics about delayed diagnosis. He was normalizing a preventable health issue, mistaking commonality for inevitability, allowing vague fear to override proactive care. Closing the browser window, Alex sat in the dark study, the ignored alarm now ringing clearly in the silence he himself maintained, a prisoner of a stigma he was only beginning to name. The true siege began after dark. What had been a daytime nuisance escalated into a nightly rebellion. Sleep, once a deep and restorative lake, became a series of shallow, fractured puddles. Alex would drift off, only to be hauled back to consciousness by that now familiar, non-negotiable pressure. Once a night became twice, then 3 times. The journey from warm bed to cold bathroom was a silent, shuffling ritual performed in the blue-dark hours of 2 and 4 a.m. each time. He would stand blearily, producing a disappointingly small volume, a meager return on the investment of a shattered sleep cycle. The daytime consequences were swift and corrosive. A persistent fatigue fogged his mind, making the newspaper crossword an impossible puzzle. His morning walks became slogs, his energy sapped before he reached the first-mile marker. Most troubling was a low-grade irritability, a shortness of temper with the mailman, with a misplaced tool, with the peaceful, humming routine of his own home. He was a man operating on a permanent deficit, his patience worn thin by the relentless arithmetic of sleep subtraction. One particularly brutal night, after his 3rd trip, he did not return to bed. He sat on the edge of the mattress, staring at the digital clock as its numbers flipped from 3:47 to 3:48. The house was a vault of silence. In that hollow hour, his earlier furtive research crystallized into a stark, personal understanding. This was noxuria. It wasn't just getting up to pee. It was a direct mechanical consequence. The enlarging prostate, that benign cellular growth, was not just narrowing the urethra. It was also pressing upwards, impinging on the very base of his bladder, reducing its functional capacity. The reservoir could hold less, so it signaled fullness more often, especially when he was horizontal and gravity ceased to aid the system. The explanation was almost a relief, a biological cause, not a personal failing. It explained the fragmented sleep of countless men over 60, a widespread but privately endured fragmentation of the self. The next morning, over cooling coffee, his wife, Alina, noted the shadows like bruises under his eyes. "Another rough night?" she asked, her voice soft with a concern he had been deflecting for weeks. Alex looked at her, at the familiar landscape of her face etched with shared decades. The stoic facade he maintained, the masculine ideal of enduring in silence, felt suddenly like a ridiculous, lonely burden. The fatigue and the understanding of the night before broke something open within him. "It's more than rough," he admitted, his voice uncharacteristically thin. "It's every night, 2, 3 times. I'm so tired I can't think straight. It's this prostate thing. It's stealing my sleep." Confession hung in the air, a stark vulnerability offered after so much quiet denial. In admitting the toll, he finally allowed the problem out of the shadows of his own body and into the shared light of their life. The urologist's office was a study in sterile reassurance. Dr. Evans, a man with kind eyes and a calm demeanor, reviewed the results of Alex's urinary flow test, the chart showing a hesitant, plateaued curve that visually confirmed his experience. The discussion was clinical, focused on metrics and mechanics. They talked about alpha blockers to relax prostate muscles, about 5 alpha reductase inhibitors to slow the gland's growth. The treatment path for BPH was laid out with clear, dispassionate logic, addressing the urinary symptoms that had brought Alex here. Yet, as the doctor spoke, Alex felt a separate, heavier question solidify in his chest, one that the conversation seemed to meticulously orbit but never address. It was the shadow in the room, the symptom whispered about on online forums but absent from the official literature in the waiting room: sexual function. Alex knew the medications mentioned could have impacts. More fundamentally, he had begun to wonder about the prostate itself, this central gland, and its intimate, nervous connections. The appointment was winding down, Dr. Evans' hand nearing the doorknob when Alex cleared his throat, the sound loud in the quiet room. He mustered the courage, his voice firmer than he felt. He asked about erectile dysfunction, not as a separate issue, but as a potential part of the prostate health landscape. Dr. Evans paused, his expression shifting from procedural efficiency to engaged focus. He returned to his stool, acknowledging that this critical link was often under-discussed, hurried over in visits dominated by flow rates and noxuria. He began to explain. The prostate, he said, was a nexus. It sat at a crossroads of vascular and nervous highways essential for sexual function. The same network of tiny arteries that supplied the gland also fed the erectile tissues. Any compromise, from the simple reduced blood flow of aging, often accelerated by BPH's demands, or from certain medications, could affect potency. Furthermore, a dense web of delicate nerves responsible for triggering erections fanned out directly from the prostate capsule. Inflammation from prostatic growth or surgical interventions for severe BPH could risk these pathways. It was a holistic system, not a collection of isolated parts. Alex listened, not with embarrassment, but with a growing sense of clarity and empowerment. The unspoken truth, once given voice, lost its terrifying vagueness. It became a biological reality to be understood and managed, not a silent source of shame. The doctor emphasized that open communication was the first and most crucial treatment, addressing concerns early, tailoring approaches, monitoring effects. Alex left the office with more than prescriptions. He carried a newfound agency. He had advocated for the completeness of his own health, piercing the professional gloss to ask the vulnerable question. In doing so, he transformed from a passive patient into an informed participant, breaking the final, deeply personal silence that so often shrouded the full journey of men's health.